Yes, yeah. So welcome everybody and thanks for joining us. I'm Dr. Taha, one of the new surgeons who joined JJ&J. First, I just want to make sure everybody on Zoom, can they hear me? Because I'm muted this side.
Oh, no. To be an IT specialist.
Okay. You can all hear me? I see, I have to mute this. Okay. All right. So the topic today, or the article that we picked up, is a nice evidence article that's been published in the New England Journal of Medicine, published I think May this year, and it's basically saying apixaban or warfarin for patients on Onyx mechanical aortic valve. Now, this is let's start as a background of why we're presenting this topic or this article. We all know the problem with the mechanical valves. Obviously, mechanical valves are more durable than tissue valves, but the issue with mechanical valves, as we all know, is we have to take care of it. Okay, can now everybody see the presentation? Okay, cool. So, as I said, patients who have valvular heart disease that's damaged and cannot be repaired has to be replaced. Now, to replace a valve, I mean, there are a couple of options. One of them is a mechanical or the metal valve, how they call it. And that valve is a durable valve that can last lifelong. But the issue with that valve is you have to take care of it and you have to use blood thinners, which is known as the warfarin. Till this minute speaking now, still warfarin is the gold standard of treatment and nothing else has came through the market. But the problem with warfarin, it has its issues and limitations, and that is, it's been affected by food, certain foods and drug interactions and all this, and you have to test regularly for INR, so it becomes very inconvenient for patients, and that's why you can see a lot of patients now moving towards using a tissue valve or bioprosthetic valve. Then this nice valve, I would say, been introduced to the market, the Onyx valve. They have the aortic and mitral valve. It's a good mechanical valve and it's proven to have low profile. And then they present this PROACT, first limb of the PROACT study, which is a prospective randomized Onyx anticoagulation clinical trial. And this trial was done for both actually the mitral and the aortic valve. The mitral valve, what they're trying to do here in this study is to try to say that warfarin, lower dose of warfarin, which gives you lower dose of therapeutic INR, can still work as good as the actual or the normal INR values for the warfarin other mechanical valves. So when they tried this study on mitral position, obviously the results was not great and they had to stop the study because there were a lot of complication, thromboembolic phenomena and thrombosis of the valve, and it has to be stopped. But on the aortic side, the conclusion was the INR can be safely maintained between 1.5 to 2, which is usually 2 to 3, after aortic valve replacement. With low-dose aspirin, this results in a significantly low risk of bleeding without a significant increase in thromboembolism. Now, they took it further, and then we come here to something called the NOACs versus the warfarin. It's been going on, and it had good results in terms of patients who had atrial fibrillation, who are on warfarin, thromboembolism, and the deep vein thrombosis and pulmonary embolus. And they had a couple of studies, which one of them clearly the dabigatran versus the warfarin patient with atrial fibrillation, and that this result was, I think, 2009. It published. It concluded that it's safe to use the direct antithrombin against the warfarin for those patients. And since then, people start using NOACs for atrial fibrillation and like pulmonary embolus therapy. Now they try this same drug for mechanical valve. Unfortunately, the same results happened. They had to terminate the study in 2013. I think before 2013, published in 2013. They also terminated it quite early because of the unsatisfactory results, and they found that the dabigatran patients had more thrombotic phenomena. So the PROACT XA is the second limb of the PROACT study, And what they tried to do now, they said, because this valve is good and we can use low warfarin in the aortic valve, what if we use now another novel oral anticoagulation, which is the factor 10A inhibitor, apixaban, and they said we're going to, obviously they got a FDA approved and ethical approved to randomize this study. And it's a randomized controlled trial, about 64 sites in the United States, 3 months. These patients had to be on warfarin in the therapeutic range 3 months before they started the apixaban. And the dose was 5 milligrams BD versus patients on warfarin. And they actually put an INR level of 2 to 3, even more higher than what's used to be for the Onyx aortic valve. And they randomized the two groups, a total, I think, of 863, almost equally, and they randomized them to two groups. They can't blind the patients, obviously, because everybody knew if he was taking warfarin or taking the oral anticoagulant. But it ran in the COVID days. It started at May 2020, and they had to terminate it again in September 2022. So just up to 2 years, and some of them actually had to terminate earlier because of the complications. So the objective of this study actually is to whether test apixaban can be effective in anticoagulation, and the other thing is will it replace the warfarin in those patients and take out this inconvenience of warfarin. So this is the flow chart or the flow diagram of the study. You can all see there it's almost equal numbers, 433 patients allocated to apixaban, 430 allocated to warfarin. So there are a couple of patients who could not receive for a couple of reasons. Some are complicated, some had other high-risk problems. So 13 did not receive apixaban in the apixaban group, and 16 did not receive the warfarin. But they were all followed up. I think mean follow-up was almost 13 months. 4 lost to follow-up in the apixaban group, and 13 on the warfarin group. As you can see, 23 discontinued interventions on this side and 24 on the other side of warfarin. 15 adverse events are reported on this side, and only 3 adverse events on the warfarin side. 1 withdrawal from apixaban and 6 on the warfarin side. So the analysis, they did 2 analyses, one for the efficacy, which they all got the analysis, like all patients got analysis on the efficacy side, and for the safety, some withdrawal, as I said, because of the complication that developed. So this is just a large flowchart. We don't have to go through all this, but that's the demographics and characteristics of the people involved or assigned for the study. And as you can see here, they almost matched everything in terms of age, numbers in both groups. They looked at all races. They looked at the valve, whether it's a redo aortic, with root or without root, and also high-risk groups. They're like 208 on this side and 189 on this side. High-risk patients are considered the ones who had atrial fibrillation, low ejection fraction below 30, large atrium, and significant vascular disease, or they have previous history of TIAs and stroke. So this is the shocking results. We all know the Kaplan-Meier failure clinic chart. This is looking at the percentage of failure here. It's 100% obviously there, but we are talking only about less than 10%. It's just magnified here, as you can see. And what we can see now, obviously, and clear, that this is the warfarin group had way less complications. It's actually below than 2. It's 1.7, if I still remember the exact value, versus the patients who have apixaban. And what are they looking at is thrombosis and thrombotic-related, valve-related thrombotic events that happen, whether they shot emboli. There are other safety values they had to stop, which is like bleeding, major bleeding, which is almost the same in both groups, but and death as well. If I still remember the 3 deaths in this study, and 2 of them died, and it's all because of valve-related complication, and 2 died on the apixaban and 1 on the warfarin. But looking at this chart, you can see how it clearly deviates and it continues to spread, and that's why it's actually terminated. And they realize that the complication is just far more than twice the normal on the apixaban group compared to the events happened in the warfarin. As you can see, 20 versus 6. And even in your valve-related thrombosis, 17 versus 6 patients, thrombotic stroke, 14 versus 0. So that is just unethical to continue with the study. And they're all proven that apixaban did not meet the criteria that they want, which is to be at least either your OPC, objective precaution criteria, there's a word there by the FDA approved. This what basically means is that you can accept certain amount of complications on anticoagulation per patient per year, and that value was put up to 1.75 and 1.79. If they exceed the twice, they had to stop. They know this is unsafe, and it's actually 4.3 for the apixaban group. So to conclude, in patients with onyx mechanical aortic valve, apixaban wasn't non-inferior to warfarin and failed to meet the safety threshold of twice the FDA mandated OPC for the prevention of valve thrombosis and valve-related thrombosis. In fact, apixaban resulted in more valve thrombosis and valve-related thromboembolic events, leading to a termination of this PROACT study. So thank you very much. I think I finished here. I would like Dr. James Felton to maybe have his input on this article.
I think as we get a more informed population out there that we're operating on, and Professor Google, we find a lot of patients go online and they say, no, they don't want to take warfarin. And so they use that as their reasoning for, either getting a tissue valve, which fails within 10 years. The guidelines are still quite clear. You shouldn't be using biological valves in patients under 65. That's still guidelines-based medicine. And the advantage is you don't have to take warfarin, but the valves degenerate usually within 10 years in that age group, especially if they're active. And a colleague of mine has had a patient now, she's 55 years old, very active, does mountain climbing and all kinds of things, and she declined a mechanical valve and took a tissue valve. And this is the patients driving it, which may be foolhardy because sometimes those valves degenerate in less than 10 years. And then you can have a TAVI, but then you're still much younger than 65, and then to have a third valve is going to be surgery when you're 75 or 80, which is when your risk is much, much higher. So I think, unfortunately, our patient population doesn't think long term. And what we've had is patients who have got mechanical valves who then say, no, but they've read on the internet about the novel oral anticoagulants. And I was just phoned the other day by one of the general surgeons where a patient who's got bleeding hemorrhoids with a mechanical valve who's taking NOACs. But it's quite clearly disadvantageous unless there's a contraindication to warfarin. If there's a contraindication, then the patient shouldn't have it. When the novel oral anticoagulants came out, there was a lot of excitement because you did not need to take warfarin and have blood tests and all the restrictions that go with warfarin that are dietary and activity related. Apixaban is one of the newer novel oral anticoagulants, only antagonizes factor 10A. Warfarin antagonizes all the vitamin K dependent factors, which is 2, 7, 9, and 10, which are part of the clotting cascade. So it actually is a more efficacious anticoagulant and has been around for decades. This only antagonizes one of those factors. And unfortunately, we can see that that's not sufficient to stop your valve clotting. And valve thrombosis is catastrophic. A stroke is catastrophic, and valve thrombosis is catastrophic. So these are not minor complications. These are catastrophic complications. So it would have been nice to have had another agent. The nice thing about the NOACs is you can stop them for 24 hours if you have to in an emergency. Usually the recommendation is 2 days. You don't have to reverse it with vitamin K and FFP if the patient needs to go for surgery. And I don't know whether compliance would be better than warfarin because you've got to take most of them twice a day. So it is an issue. We'd like to have a valve that doesn't need any anticoagulation, but that valve does not yet exist. And the Onyx valve so far is the least thrombogenic of the mechanical valves on the market. And that's why it's the preferred valve, particularly in the aortic position. Apixaban was associated with more bleeding complications in patients with atrial fibrillation, but appeared to be more efficacious than dabigatran and the other novel anticoagulants. And I think that was the reason for doing this study, hoping that we'd have something efficacious. So it's not better than warfarin. And, this is a really important paper because patients will, the way the internet can reinforce falsehoods sometimes. This is where you go for your information. I think the impact factor of the New England Journal of Medicine is important, and we can use this study to give patients proper informed consent when we're deciding about what valve to use and are you going to take warfarin or not. Anything?
Thanks.
Anyone else got something to say?
So what do you guys do in a scenario where you have these patients that demand having tissue valves at the wrong age to avoid warfarin?
It's quite challenging because you sit with them and you keep explaining, like, listen, you're too young, you should have a mechanical valve and you should do this and that and take the warfarin, but they still insist on a tissue valve because I don't know if they hear that patients just constantly bleed and complicate because of warfarin. Look, I understand very athletic, like active people who don't want to, can't play rugby on warfarin and stuff. But if it comes to the age where it's like, especially in the aortic position, if you sit with a patient who's like 60 or 55, I think we're going to lose the battle with trying to convince them for a mechanical end because of the valve-in-valve thing coming now. That's why try to get in a big tissue valve, and then later on you don't have to go for resurgery, you might just get in a valve-in-valve. But the younger ones, I think it still has to be mechanical and they still have to go for warfarin. I mean, I understand this is a very strong paper, strong evidence, but it's unfortunate for us. We really would like a more durable drug that, just take it, you don't have to think about it, and it's as good as warfarin with less complications. And it's in the US as well. Clearly, there's this article I read that they still use this NOACs with patients with valves, and it's there and here, but no one can justify that.
I think this is the patients that drive this, or contraindications to warfarin. But I think until a patient has a stroke, it will tend to change their attitude quite profoundly about whether you should take it.
Yeah.
I mean, a stroke is often a permanent, life-altering complication.
Yes.
So I think that from our point of view, we'd much rather a patient doesn't have a stroke after a valve replacement. And I think we don't have evidence for the valve-in-valve in young patients as a TAVI procedure. It's a nice idea, but there's absolutely no evidence. So it's all what we would call off-label use. And it may end up being really problematic in the future that you're going to be operating on somebody who's got two valves and he's 75 or 85 with multiple coexisting comorbidities, and now you must go and operate on. So, that's putting the surgeons in a corner with no escape, except maybe a dead patient. So I think that we've got to still think carefully about this, and patients, ultimately, they're going to make these decisions, but they shouldn't be allowed to make a foolhardy decision.
Yeah, I agree with you.
I think you must print a lot more of these for your rooms.
Now, I had one patient actually tell me he doesn't want to take warfarin. Just says, and so I actually had to, in the end, because he'd read on the internet, so I sent him 6 articles and said, right, fine, read this, and you can decide. And he said, no, fine, he doesn't want warfarin. But that's the patients are driving this now. And sometimes,
And he already got the valve.
No,
Oh,
before
he's
the valve.
before the valve.
And I think the
So did he say he will have movement after you
Yeah.
sent
Oh,
him?
yes.
Was he convinced?
after he
okay.
saw that the stroke
Yeah,
rate
okay.
was very-
Okay. So he actually read it.
Yeah.
Wow.
But yes, the but I'm not going to put a mechanical valve with it. You're not going to put it. Yeah, well, I think again the problem is if you're 53 or 52 years old, that's a very bad decision. Yeah. And so I had one patient that convinced me at 53, and within 5.5 years his valve had degenerated. He actually didn't end up having repeat surgery because he developed multiple complications from the valve, went into renal failure and subsequently died. The patient should never have got into that mess. Um, and so I think that it's unpredictable. Valve degeneration is very unpredictable. Some people that just walk around and do nothing, like 75-year-olds, that's where all the studying has been done on tissue valve durability. It hasn't been done on 60-year-olds because we don't put it in. But we know the more trauma there are to the leaflets of the valve, the increased risk of valve degeneration. So young active people are probably going to end up with valve degeneration much sooner than 10 years. And then we're going to have a problem. Then you can have your TAVI at 61, and then you need redo surgery at 71 or 74. So we don't have the answers. So we've got to go with best evidence at the moment.
I agree.
Okay.
I also last comment.
Sure.
So I think in private versus state patients is also an issue because I worked most of my training and where I worked is in a state, and we find it very difficult for very younger patients in the 40s and to actually put in a mechanical valve, and the issue is the compliance and where they're going to get the INR testing and all that, and we just sometimes forced to put in a tissue valve in those patients. I think it's just more safer for us. Unfortunately, I know they're going to come back to operation, but you can't just put a mechanical valve in an uncompliant patient that we can't actually access INR testing.
But they will be generally doing it.
I understand. Now, I've seen like
Even
you know,
less
after
than
2
5
years.
years,
Some patients came 2
Yeah.
years later on with a stuff.
Okay, I think let's move on to the second part, which is our US.
If you just zoom in there for us. So these are the beginnings of the stats we've collected now for June. We launched our ERAS cardiac. We've launched the ERAS cardiac program for JJ&J on the 1st of June. And these were the 12 patients we did. Yes, that's cool. Thank you very much. So I also just want to remind everyone in this discussion, if you recognize any of these patients, please be careful not to say their surnames. Okay, so we're just working with our initials for the PAPI Act. All right. That include, this is a reminder for myself. Okay. Okay, so you can see we've color-coded the patients on red, green, or orange, a bit like a traffic light. And we've made a decision on how to classify the patients. It's according to risk. So I don't know if you've noticed in the WhatsApp groups that you are part of on ERAS, some of you, we post something called the Euro score. And we've decided now that we're going to make an effort to post it right in the beginning, pre-op, so that everybody knows where we're at. We said a green patient, so this is going to be someone we're expecting to achieve all our goals with, is going to have a Euro score of less than 2%. So that's a expected mortality less than 2%. An orange patient will be between 2 and 6% on the Euro score, and then anything above 6 will be red. We also said any patient that gets a balloon pump pre-op for the induction will also fall into the orange category because we know there's challenges on day 0 for achieving our goals there. Okay, just to help us a little bit so that we don't feel deflated if we're not achieving the goals, that we can give the patient the right expectations. But we've also made a decision that even on the worst red patient ever, that we will be doing ERAS on them. Remember, the goal for that patient is enhanced recovery, not fast extubation. Okay. So if they in the past would be discharged on day 40 and we achieved day 39, it was worth it. All right, so that's what we've decided as a group. I do maybe want to just talk a bit more within our own group about whether or not to give them a different diary for those ones that we're expecting. Maybe we must design something a bit more realistic for them. So we'll think about that. Do you guys maybe want to explain anything more about the Euroscore while we add it to the rest of the team that aren't used to the Euroscore?
Now, the Euroscore is just a mortality predictor. So just your risk of dying. And obviously as your risk of dying goes up, your risk of all the other complications associated with open heart surgery go up, such as prolonged ventilation, bleeding, renal failure, deep sternal wound infection, and so on, delirium, all the things that keep the patient stuck in ICU. So, and although it's a very simplistic and easy to understand set of variables, it actually is very powerful. You can get a very good idea who's going to give you trouble based on the Euroscore and the acuity of presentation. The STS score does give you the risk of those other complications, but again, it's more complex. There's more data points to enter, but the actual raw data is not very different. So, for ease of application, we use the Euroscore, which is just those parameters there, so you can get a pretty good idea about how to do the scoring. And of course, it depends on us always getting all the data points, but these data points are usually pretty easy for everybody to understand.
Okay. Thanks.
And this is an app you can all download on your phone. It's there. You can just, while in your phone, you can calculate.
And it needs to be the Euroscore 2, is that right?
That's the Euroscore.
Okay. Okay, cool. So then, just to share with you, we're still going to be collecting all the data points that we originally did so that we can compare in 6 months' time. But for the sake of our monthly meeting, I just picked out probably the most important, I thought. So we've got there also a classification of elective, urgent, or emergent surgery, the Euroscore, date of surgery, length of stay, and I just want to already highlight that our record for June was a 4-day length of stay for a cabbage. And then also what impressed me quite a lot were those 2 that were orange that had a length of stay of 6 days. I thought that was very encouraging, that perhaps in the past we would have underestimated those patients, and they did exceptionally well. Those were the 2 that were done in St. Anne's in the earlier part of June. Okay, and then we're going to split those days into ICU and ward. We've got our theatre times being measured, surgical time, bypass time. I think we must also just add a column there for anesthetic time. We've got the multidisciplinary team members there, total intake, intra-op, which we've sorted out now with our perfusionists, and we're doing it consistently now. So I think that's all that really matters, is that we measure it the same way every time. Time to extubation has even decreased further in July. We're now getting a time to extubation of 1 hour. So we've improved, I think, in 6 weeks from around 2 to 4 hours to 0 to 2 hours already. Obviously, not always possible, but on those nice green patients. And then the physios have done an excellent job. Almost every single patient without a balloon pump was mobilized on day 0, day 1, 2, and 3. So well done to you guys. The dietitians are also doing very well, but I think there's still a lot of challenges with nausea with our patients. So we're not getting the regular diet on day 0. It's very difficult. Even day 1 sometimes has a challenge, but then you'll get like a random patient that will eat a chicken mayo sandwich. So I'm not sure what the difference is, but Yeah, we are winning in comparison to where we were. Okay. And then we're collecting the pre-op HB, what blood products, if any blood products from Sanbus, I'm talking about not cell-safe blood, were given on day 0. And then we're measuring some more HBs and creatinines. And then this one isn't on the data points that we got from America, the HGT under 10. But as it is a guideline, I think we need to add that one in. And then, of course, we've also got what antibiotics were used. And I did notice some patients got Targacid instead of Kefsol. We know that there's some high-risk patients out there, but we had some green elective cases that got Tazocin, I think, once. So maybe we must... Targacid. So maybe we must just be aware of that again. Just remind us again, what are the high risks that should get Targacid?
I think just a few things. If you look at the STS recommendations, they don't use Targacid at all.
Okay.
They use Kefsol and vancomycin as their prophylaxis. For the penicillin allergic patients, get vancomycin. And they would give gram-negative cover for the patients that you think are at high risk. But most patients are not at high risk. But that seems to be a bigger problem in the United States. So the recommendation is to use Kefsol. Failing that, you must use Vanco. The high-risk patients are the patients that have had prolonged ICU stay, multiple ICU admissions in the recent past, and patients with insulin-dependent diabetics, and people on steroids. They're all at risk for MRSA infection. And we've proven that with us, that when we do the swabs, when the patients get admitted, we'll find that's the population that have got MRSA. So Kefsol's probably not appropriate in those patients. But we need to revisit the antibiotic prophylaxis as per guidelines. I know at Mill Park we were using Vanco and Kefsol. Kefsol for the uncomplicated, Vanco for the complicated. Yeah, there's a bit more to it than that.
Okay, so maybe we need to discuss that in more detail at some point. And then we also have reduced our days for our devices, drains, catheters, and CVPs. I hope that on our next meeting I can give you a much fuller page of data. Okay. And then a nice data point is how many days of prehab. And I also just want to remind our surgeons to please refer to the ERAS clinic or the ERAS team as early as you can. Don't sit on the patients and then, oh yes, we've got a bypass in 2 days. I think the prehab does make a big difference. We just need to get used to the system. I think we missed a few days on some of our patients. We missed opportunity. Okay. And then we just put a extra column for any complications that our patients had, and then any other comments. After our last meeting, I really had it strongly on my mind after the clinical manager here was talking about the psychology aspect that she felt was missing. So I thought the way I just handled it now this month as the coordinator is we didn't make a psychologist a must in the program, but I offered it to every single patient. If they were smokers, if there was a problem with alcohol intake or any social issues or even any emotional issues, which a lot of them are quite anxious, I offered it to them, and some of them got referred to a psychologist as well. And I think we must encourage them, because I can see that there's definitely a bit of a stigma about having a psychologist with our patients. So we must just say, take all the support you can get. This, Okay. Cool. So I thought that was nice. Yeah. What else we wanted to discuss today was the protocol or the orders form for post-op. Mediclinic wants to document control that form. They had a lot of requirements to be added, which we've changed. But the only point that I can't finalize, and I'm getting quite a lot of pressure because they don't want us to use the form without that, is we can't prescribe a NovaRapid infusion without a sliding scale going with it. So we did have a little bit of a discussion in the WhatsApp group, but I just want to finalize it today, hopefully. And the Jones Bhagwan tight glucose control looks very intense and it covers all bases, but it's too long to include on our protocol. So what I wanted to suggest is that we use a simplified version, but then of course, if any of the doctors feel like if the patient's diabetic, for example, and it's not adequate, or for whatever reason you feel like it's not adequate, you can just I'll put a block there so you can activate it. But if you're not happy with that sliding scale, then just write there, use Jones Bhagwan tight glucose control. Then you can use either one. Would that be okay? Would that be all right? Just to finish the page. Is that okay? Okay. All right, cool. Then I'll do that. Thank you. And then I also just wanted to remind everybody, the WhatsApp group would be, I think, more useful if every person in the multidisciplinary team would just write like a sentence after your round. It doesn't have to be too involved. It can even be no problems, everything going well. Or patient is still nauseous and vomiting, we need to do something more about this, or whatever it is. Just a short sentence so that, and it's not for, it's not to report to me. It's for communication within the whole team. Okay, because you guys don't see each other at the bedside, and I don't think anybody reads anyone else's notes. So you just work in the silos then, and we just go back to what we used to do. So please just write one sentence, and I think it might feel like a lot of work, but I think on any given day you probably only have 1, 2, or maximum 3 of these patients. So I think it's manageable. I also really would like the nursing staff to be more involved in the WhatsApp groups. You guys are the ones that are there that know exactly what's going on with these patients, and you see the changes and the problems come up first. So I think we must just make everybody in the group admin so we can add the nursing staff on a daily basis. Okay. And then also, now that you're more aware of these data points, I've also asked the surgeons to please just post in the WhatsApp group, because we can't get the data retrospectively without a hell of an application to the hospitals. So we do it in real time to collect the data. But it's quite difficult for Dean and I to run around every day and check what's changed on the patients. So we'll do one where we get all the theatre times and we'll go into detail. But then can you please just post catheter out, CVP out, drains out, going to the ward, and discharged. Discharge seems to be the one that's missing the most. Once the patient goes to the ward, this WhatsApp group just goes dead quiet. Okay. So if we can just try and help with those few points, the practical elements of the patient care. Okay. And then I did make a little note here. Just give me a second. Yeah, that was all I wanted to say. Did anyone else want to comment about something that you've noticed? Oh, I did have a point I wanted to ask the physiotherapists. So we have noticed our patients are still seem to be quite prone to chest infections. Not sure if it's appropriate or expected, or where it's coming from, and I don't think it is expected to have a chest infection after open heart surgery, but our patients still get this quite often. So we need to figure out where this is coming from. Like, how does it happen? Are we compliant on the contact precautions? Do we have an environmental cleaning problem? Is it a hand washing issue? Is there a piece of equipment floating around that's not going through a proper process? We need to try and figure it out why. And I've noticed something that I'm going to give to them, and that is, I don't know what you call it, but that's alternative to the spirometer with the water in it with the pipe. So it's what do you call that thing? Okay, so it's open, it's got water in it and it's got a sticky plaster around it and it lives in the ICU and it follows the patient to the ward. I think I saw Mr. R, one of the first patients. Woo, I didn't say the surname. His was with him for like 3 weeks, and I was just wondering, how do we know that that isn't the source of our infection? Because I remember Jackie actually said that the spirometers should be covered and we should maybe sterilize them, but now we've got this thing that's wet, which we know is a disaster for contamination, and open and sticky. So I just want to know about the infection control of that device, and is it really worth making something when I thought you can just turn the spirometer upside down for the expiratory exercises. I'll put it to you.
Only the blue one does that sometimes.
So then can we not just change to blue?
Gloves as well.
Maybe the
And
gloves
gets thrown away.
gloves are a much better idea then. So if you've got the red spirometer with gloves or the blue spirometer, I think that's a better idea for infection control. Okay.
It's a very easy way to find out.
How?
You
Swab
just
it.
swab it, yeah. I think you might be surprised. I mean, it's any inanimate object that stands for 2 or 3 or 4 days is bound to be colonized. And it's probably not the right thing for a patient to be. And I think, I mean, with that particular patient, I mean, he was very sick before the operation, so I don't think we could say that was the source of his chest infection.
No. But I just wondered about it.
And maybe the spirometer can go in the mouthwash, just be dipped in that, what do we call it?
The corsetal.
Daily. When they do the mouthwash, maybe just rinse that as well. I don't know. But then it's not necessarily just the mouthpiece.
So when I was a young nurse, we were always told to wash the nebulization masks once a day with Hebe scrub, and then they have to let be dried, and then they could use it again. So maybe that we can just use that same principle. Okay, maybe we can put it to the IPC team and ask them for some advice about how to do it. People that actually know about this stuff. Okay.
I don't know about hand washing. The patients actually get their hands specifically washed. I know they get washed, but their hands also everywhere.
Dirty.
Yeah. They're probably colonized too.
Maybe to wear a mask when we treat the breakfast patients. Just in terms of safety.
So the only precautions that we use on these patients is standard contact precautions, which is just apron and gloves. If you feel sick, obviously you need to wear a mask, definitely. I don't know. Any other comments about this past month's ERAS?
I've noticed the pain has been a lot less, like almost unbelievable. I don't know if it's the particular pain meds or if it's taking the brace away where they don't feel like being reminded of the pain, but the pain factor is very
It's
different.
actually been quite notable. We have been doing a block, but even the next day, they're still having less pain for some reason.
No, they're injecting a local anesthetic.
Maybe
to the
just,
sternum in theatre.
Yeah.
But definitely they've been happier,
Yeah.
but weird.
But I think also if you don't have that initial pain, it doesn't, because that can almost be carried with you.
Yeah, it has a psychological element now,
Yeah.
being afraid of the pain.
The motivation definitely is better, but I think the effect of that block carries on. I think it does help into the next day as well.
And maybe the early mobilization also, like for body ache per se, probably helps too, that they're already so quickly on the move. Yeah.
I think everybody that's been involved has done a great job.
Yeah.
Patients are undoubtedly the ones that are supposed to do really well.
Okay.
So I think it's
Yeah.
been a great effort from everybody, from anesthetic,
Yes.
dietitian. The diet thing was also, for me, has been a revelation because I wasn't sure about it because we don't do this normally. But some of the patients are amazing on the first day. They actually sitting in a chair eating dinner.
Yeah. If they're not, they don't have proper nutrition, then the physio falls apart, and then the whole thing falls apart.
I think it's a big psychological component. Patients, when you say we're going to do your bypass and maybe we'll extubate you if you're okay, otherwise we'll do it the next day, and then the next day they don't get out of bed and they don't eat,
Yeah.
and it has been like a remarkable difference in the right patients. Obviously, it's not for everybody, but this is we can apply the principles to all our patients. But the cost saving, I think, on these patients would be probably the order of 150,000 rand a patient. What we've saved on the patients that have followed the ERAS, and I suppose it's more money for the medical aids, but maybe we can have more patients to operate on in the future.
I also wanted to just ask the team's experience on the coughing cushion. How's it going with that thing versus the brace?
There's one issue.
Okay, let's hear.
The only issue is when they walk up and down stairs, they can't see their feet.
Okay.
That's the only
So
problem.
we've asked for the makers of the cushion to add a little handle, little strap, so that they can just hold with it, so they can just take it with. Yeah. So we'll try and design it a little bit more friendly. We also got feedback that it's too slippery. Patients can't grab it because it's like a velvety suede stuff. They struggle to grab it. Yeah. But otherwise, I think it's going very well with it. I hope you can see. I know there were a lot of freaked out people that we were taking the brace away. I hope some of you can see that it's okay.
That's what we should be doing. And some of the intensive care, the intensivists should be involved with that as well. Yeah, better than we did it in Mill Park every week.
I think they do it here once a month. Is that right? But they have a round once a month.
Microbial round with a micro, because the point is it's pointless having those rounds without the practitioners being part of it. It creates this idea where somebody has an idea and tells some people, but not all the people.
Okay.
And then, people just carry on doing what they've been doing for the last 25 years.
Okay.
Which we know some of it's good, but some of it's not good. And I just put on the group the 8 from 8 talk that was on the STS the other night about antibiotic prophylaxis, the guidelines as per the STS.
Okay.
And those might be worth looking at.
Okay, can I quickly just ask everyone, you don't have to participate if you can't think of anything. Can I just go around the room and then will you guys just share very short, like your favorite, your best ERAS moments from June? Okay, you're on the spot.
I think our first patient
Watch out for the patient
that
names.
got into the chair on day 0, it was very momentous. It was quite scary for all of us, but it was very good, and he did amazingly the next day. That's what proved the day 0 mobilization.
Yeah, day 0 is definitely worth the trouble when you see it day 1.
For our team, it would be the patient that ate on day 0 and ate like a chicken and mayo sandwich. That was incredible because we expected, something a bit lighter, but this patient finished the entire sandwich and that was phenomenal. And also to know that the patients have been quite keen with the pre-op and with the pre-rehab as well has been really nice to see that they're so keen.
Awesome.
I think for me it would be the day 1 mobs. So the specific patient basically walked as if no surgery had happened. So that's not common for us to see as physios day 1. So that's quite different.
Cool. Mervyn, did you have an ERAS moment? No? You just did.
I would say that our first patient, that procedure was done on Tuesday and he was discharged on Sunday. That was amazing for me.
Cool. So like a day 5
Basically.
discharge. Anything?
No.
Shame the theatre's not getting these moments.
We're not getting these moments.
Not-
I think for us, it's just that we've improved on our timing of getting our patients in theater. Just a little bit of a hurdle when the patients have balloon pumps, then that causes a slight delay. But either than that, I think we're making it good time.
Thank you very much for that buy-in. It's making a huge difference. Nothing?
I got a call when we were at a hospital about a previous patient that we did, and it was 11 days after his surgery, and he was at home, and he was like a real chill guy. He's like, yeah, no, I'm up, I'm running, and I'm like, are you serious? He's like, yeah, I found out your accounts. I was like, oh, but he had all this energy, and it's like 11 days after having this big surgery. Granted, he was young, but he was so chilled and grateful on the phone. I was like, okay, this is nice.
Best ERAS moment of June.
Craig.
No names.
That's his first name.
The day 4.
Yeah.
Day 4 discharge. Okay. ERAS moment.
Last moment. So, I think I don't want to mention names because I always like to mention names. I think that patient that left third day actually to the ward, or second day to the ward, was something very nice.
Yeah.
Unfortunately, if you look at in the ward stay, it was a bit longer, but it had nothing to do with the procedure.
His recovery wasn't slow. It was
Yeah.
he just needed some antibiotic.
Yes,
Yeah.
yeah, but he did very well, and I was so glad. Yeah, thanks.
I think all of our patients are definitely more positive. Before they used to be like, I'm having a open heart surgery and very afraid.
Yeah.
Now they like go-getters. They want to do it, which is actually quite scary, you know?
Like, where's the fear?
Yeah, you know, that type of thing. But otherwise, for us in the units, it's culture shock. You know, you've just come back from theater, mobilizing, sitting in the chair. But baby steps, we're getting used to it.
Okay.
Yeah.
Cool. Thank you.
I think for us, it's been the whole team approach. I think it's been really amazing working as a team and just feeling part of a valued system. So, yeah, that's been really cool.
Yeah, well, I agree with Alicia. I think it's made a big difference in theatre. And also, I think everybody is much more involved now.
Yeah. I think for me, it's about kind of what Lucinda said, having the patient as part of the team. I love these patients. I'm sure it's annoying to the nurses, but the ones that remind the people that they need to do spirometry now, they're very much driving parts of their care, which I think helps a lot. I think getting their buy-in is the key to the success, or one of the keys. Yeah. Thank you very much for everybody trying so hard and your positive attitude. It is a big mind shift, but I think we can see it's making a big difference. So thank you to everybody. I think we can end our meeting. Thank you for coming, and please have something to eat before you go. The dietitians, close your eyes. Thanks, everyone. Bye.